Hello and welcome to my channel. Today we'll be discussing the small intestine, the duodenum, the jejunum, and the ileum. The small intestine, as we studied before, it's all a continuous tube. The small intestine part is about around 6 meters long, and it's divided into three parts: the duodenum or duodenum, and the jejunum and the ileum. The duodenum is the proximal part and is the one attached to the pylorus. The duodenum is the shortest and widest part of the small intestine. Begins from the pylorus and goes to the right and slightly upwards, then forms the superior duodenal flexure, and then descends that was the first part. Then the second part descends on the hilum of the right kidney, as you can see here, and then ends by forming the inferior duodenal flexure. Then it turns to the left, slightly raised upwards, crossing the aorta and the inferior vena cava, and this is the third part. And then the fourth part, which is the ascending part, back to L2 level, forms the duodenojejunal flexure, as you can see here. So it has a first part, second part, third part, fourth parts. The first part is 2 inches long. The second part is 3 inches long. The third part is 4 inches long, and this part is 1 inch long. Okay, and the C-shaped duodenum encloses, as you can see here, the head and the uncinate process of the pancreas. From this position, you can actually depict the relations of the duodenum as it goes through its parts: the superior, the descending, the inferior, and ascending. Now, the first part level is L1 vertebra. The second part is L2, actually all the length of L2 till it reaches L3, which is the level of the third part, and then the fourth part ascends again to the level of L2. Please remember the levels, it's important in your study. This is the description of the duodenum. It's mucosa. It's thick and thrown into folds. As you can see here, they're called the plica circularis. The plica circularis is to increase the surface area of the mucosa. Now, for the duodenojejunal flexure, it's raised up, right, back to the level of L2. Something should be keeping it in place. It's a ligament called the ligament of Treitz. This ligament formed by two parts. Lower part, extension from the wall of the duodenojejunal flexure itself, which is a smooth muscle part, and stapled to the posterior abdominal wall by a piece of connective tissue, and coming from above, as an extension from the right crus. Remember this when we discussed the diaphragm. There is an extension from the right crus that descends downwards to the same piece of connective tissue, stapling the inferior band and the superior band to the posterior abdominal wall. Altogether, of course, it's coming from the right crus, so it's skeletal muscle. This part coming from the intestine is smooth muscle. These two limbs, not showing here, of course, on the posterior abdominal wall, are the components of the ligament of Treitz. The duodenum itself is retroperitoneal, except for the first centimeter of the first part, which is highly mobile. It doesn't have a mesentery, but it's enclosed above in the lesser omentum and below in the greater omentum. Remember this because it's the site where the hepatoduodenal part of the lesser omentum is attached. So remember this. It shows in X-rays as the duodenal cap. It's the highly mobile. It makes sense. It's logic because the stomach itself is highly mobile. So you can't attach a highly mobile organ to a strictly fixed organ. This will produce a strain on the pyloroduodenal junction. Uh, at the duodenojejunal flexure, as you can see here, I tried to simplify the idea of the folds formed by the peritoneum. As you can see here, see these folds? This fold and this fold. These are called the paraduodenal folds. And accordingly, subsequently, they have recesses underneath. See, this is a recess here and the recess. These are sites for impaction of hernia. A loop of intestine gets impacted in the recess. So remember the superior and inferior paraduodenal folds. There's also a lateral fold, paraduodenal fold, which is raised by the inferior mesenteric vein passing underneath. Inferior mesenteric vein. So the paraduodenal folds, two of them because of the flexure itself underneath the peritoneum, and the lateral one is because it's raised by the inferior mesenteric vein. This is important to remember about the paraduodenal folds and recesses. This is a duodenojejunal flexure here, as you can see. Now for the relations, we will discuss relations of each part. This is the first part. The first part related anteriorly to the neck of the gallbladder. And as we said, it's as we learned, it's the most mobile. Anterior to the liver, the neck of gallbladder, the quadrate lobe of liver. Posteriorly, as you can see here, this is the gastroduodenal artery. This is the hepatic artery, and the common hepatic artery dividing into hepatic and gastroduodenal. See how it descends behind the first part of the duodenum, the gastroduodenal artery. This is very important clinically, since one of the dangerous complications of duodenal ulcer, especially if it's on the posterior wall of the first part of the duodenum, is involvement of the gastroduodenal artery means a source of internal bleeding, and this is a dangerous consequence of the duodenal ulcer. See, you can see the relation here is very, actually it sticks to the back of the first part of the duodenum. It also has the common bile duct and the portal vein posteriorly before they open into the second part of the duodenum. Now for the pancreas is an inferior relation of the first part, is a medial relation of the second part, is a superior relation of the third part. It's logic. Again, it's inferior relation of the first part, medial relation of the second part, and superior relation of the third part of the duodenum, and right relation to the fourth part, with the body is being superior to the fourth part, the body of pancreas. Here we were talking about the head and uncinate process, and here we are talking about the body of the pancreas. Now for the second part, the descending part, which descends on the hilum of right kidney. So it has the hilum of right kidney behind it, means the pelvis, means the right renal vessels till it reaches the psoas major muscle. Anteriorly, it has the right lobe of liver in front of it, and the body and fundus of gallbladder. So why we're stressing on the neck of gallbladder and here the body and fundus? For the fistula, if a fistula developed during a cholecystitis, it may involve the corresponding part, nearby part of the duodenum, which will produce a sign in which there is vomiting of bile bile containing the vomitus contains bile from the involved gallbladder. Remember that it's crossed by the transverse colon, and here the right colic flexure should be at the right side of the second part of the duodenum here, but this plate is wrong. The right colic flexure should be on the lower pole of the kidney, of the right kidney, not at the right side of the right kidney. The left colic flexure is at the left side of the left kidney, but the right colic flexure should be at the lower pole of the right kidney. The common bile duct, as it descends behind the first part, then becomes posteromedial to the second part, joins the main pancreatic duct, as you can see here, to form the ampulla of Vater, and opens at the summit of the ampulla as it pushes the mucosa of the duodenum to form the major duodenal papilla. So the major duodenal papilla receives the opening of both the joined common bile duct and the main pancreatic duct. Now the accessory pancreatic duct, which is this one, draining the uncinate process of the pancreas, it crosses up inside the pancreas and opens in another papilla, but above the major one, called the minor duodenal papilla. So the minor duodenal papilla receives the opening of the accessory pancreatic duct, while the major duodenal papilla receives the opening of the joined common bile duct and the main pancreatic duct. And this marks the end of the foregut and beginning of the middle gut, or the midgut. The artery of the foregut is the celiac trunk. The artery of the midgut is the superior mesenteric artery. You will depict that. You will know after studying the blood supply of the duodenum and the pancreas. So the third part, which is the transverse part, it crosses the inferior vena cava, crosses the right cross of diaphragm, crosses the aorta, all this posteriorly as it go from right to left. Anteriorly, it's related to, first of all, the mesentery of the small intestine starts to form here, so it crosses, the root of the mesentery crosses the third part of the duodenum. Also the superior mesenteric vessels, as you can see here, this is the superior mesenteric vein, this is the superior mesenteric artery, crossing the third part of the duodenum, coming in front of the third part of the duodenum. And superiorly you have the uncinate process of the pancreas. Anteriorly it's related to the superior mesenteric and root of mesentery. Okay, so this is the third part, which is at the level of L3 vertebra. The fourth part, which is this one, the ascending part, the short one, at the level of L2, that forms eventually the duodenojejunal flexure. Anteriorly, it's related to the transverse colon and mesocolon. Superiorly to the body of pancreas. Now we are at the level of the body of pancreas, see, not the head and the uncinate processes. And the right to the root of mesentery, as we studied that, as we learned, it will start here and descends in this oblique fashion. Posterior to the left sympathetic chain, the left crus of the diaphragm, left psoas major, and left renal and gonadal vessels. To its left side is the left kidney. You can see here the left kidney to the left side of the fourth or the ascending part of the duodenum. So remember the different relations of the pancreas to the different parts of the duodenum. You don't learn them by heart. It's logic, a C-shaped with the head of pancreas inside it. Now, we can make use of this take advantage of this. If we performed a barium meal and x-rayed the patient, complaining of signs of something wrong with the pancreas, like a pancreatic tumor. If there is a pancreatic tumor in the head of the pancreas, there will be widening of the C of the duodenum, and this is the importance of this relation. Thus, widening, a change in this organ reflects the change in the nearby organ, which is not visible in the X-ray. Widening of the C means there is something wrong, mass occupying lesion in the region of the head, and the uncinate process of the pancreas. For the blood supply of the duodenum, we said the upper part belongs to the foregut, the lower part belongs to the midgut. So you expect the upper part to take from branches of celiac, exactly like what's happening here. See, these are the superior pancreatico-duodenal branches of the gastroduodenal artery, which comes from the common hepatic of celiac. These are the superior pancreatico-duodenal. The gastroduodenal itself supplies the duodenum, the first and second parts. Then, as you can see here, these are the branches of, this is the inferior mesenteric artery. These are the inferior pancreatico-duodenal and the duodenal branches supplying the rest of the duodenum. It's very clear here and neatly dissected. As you can see, the branches, inferior pancreatico-duodenal arteries. There is an MCQ about the superior mesenteric artery, which is the first branch. Most of us forget the inferior pancreatico-duodenal. The inferior pancreatico-duodenal arteries or branches are the first branch of the superior mesenteric artery. Of course, the venous drainage is a rule back to the portal vein. Always back to the portal vein. Here it's the portal or splenic or superior mesenteric. Lymphatics to the celiac lymph nodes eventually, and then to cisterna chyli. And innervation comes from the plexus around the vessels derived from the celiac plexus, carries the sympathetic and parasympathetic supply of the duodenum. Of course, the parasympathetic is secreto motor. The jejunum and ileum, longer of course and narrower than the duodenum. The jejunum is wider than the ileum. It's more vascular and reddish in color. The mucosa is thick and gives a feathery-like appearance in barium meals. You can see here, the feathery appearance. This indicates that these are loops of the jejunum. These are loops of the ileum. You can note the difference between the mucosal folds here and here. Here at the distal ileum, it's almost smooth without folds, but very few folds, as you can see here. The jejunum is wider, more vascular, and has more number of plica circularis in it. And it lies in the umbilical region. All the coils in the umbilical region belong to the jejunum. The ileum, on the other hand, is narrower and thinner wall, few plica circularis, but as you go distally, increased number of lymph follicles, especially on the antimesenteric surface of the ileum. Antimesenteric means the surface opposite the surface facing the mesentery of the small intestine. It looks like white patches on the antimesenteric surface called Peyer's patches. It's lymphoid follicles, full of lymphoid follicles and part of the immune system. The mesentery itself is a double layer, of course, coming from the posterior parietal layer of the posterior abdominal wall, as the intestine invaginated the posterior layer and descended, protruded forwards to take a mesentery behind it. The root of the mesentery is oblique, starts at the duodenojejunal flexure here, then descends crossing the third part of the duodenum, the aorta, the inferior vena cava, the right psoas major with the right ureter and gonadal vessels, and ends at the level of the sacroiliac joint. So this line represents the root of the mesentery of the small intestine. What doesn't contain? Contain the blood vessels for the small intestine. Of course, it's all branches of the superior mesenteric artery and superior mesenteric, the tributaries of superior mesenteric vein, lymphatics, nerves, and fat. The fat being more at the ileal side of the mesentery. As you can see here, about the stomach, the incisura, and the duodenal cap for the first part of the first part of the duodenum. This one, this area. Now, there is a congenital anomaly involves the terminal ileum 1 meter from the ileocecal junction. There may persist the remnant of the vitelline duct. This duct used as a fulcrum around which the intestine rotated in the fetal life and then went back to the abdomen again. Now, if this duct persists, it will be connected to the umbilicus from the inside, and by this connection, it acts again as a fulcrum but the intestine here, there's no desire to rotate the intestine here. This is abnormal. It will rotate around this fulcrum. This will strangulate the blood supply of the intestine in the mesenteries, this case is called a volvulus, in which infarction of the affected part of intestine, and of course it needs surgery. It's a life-threatening situation if there's an infarction of part of the intestine. Now you can see the importance of the mesentery, in which it holds the vessels and nerves, all these network of vessels and nerve together in one plane. However we move or change position, the vessels will retain their relation with each other. They will not get intermingled or strangulated. This is crucially important for our survival, of course. The importance of the mesentery. The blood supply of the small intestine, the jejunum and ileum, now this part from the superior mesenteric, as you can see here, the superior gives numerous branches and forms what so-called the arcades and vasa recta to supply. We will see them in the next plate that supplies the intestine. This is the way the superior mesenteric supplies. Lymphatics along the vessels, and the nerve coming as a plexus around the vessels, as we mentioned before, sympathetic and parasympathetic from vagi. Here you can see a piece of duodenum. How did I know? Because the arcades are few. They are not as numerous as the what you will find in the ileum. And the vasa recta. See the vasa recta, and the vasa recta are long vasa recta, and fewer arcades. If we make a comparison here, this is part of the ileum. See, this is shorter vasa recta. The vasa recta are short and more arterial arcades. See, they call these windows between the arcades. Windows, more windows and more arcades. But as you can see here in the jejunum, the longer vasa recta, due to the fact that there are lesser arcades formed at the jejunal part. This is a major difference between the blood supply of the jejunum and the ileum. Now, for the last thing, I displayed just to show you the mesenteric lymph nodes scattered all over the mesentery to drain the small intestine, and eventually to the superior mesenteric lymph nodes, part of the pre-aortic lymph nodes, and then to the celiac lymph nodes, then to cisterna chyli and the thoracic duct. Well, this is what we have to say about the small intestine. I hope you got the maximum benefit of this lecture, and thank you very much for watching.